Yes, okay. So I want to spend a few minutes finishing up the discussion from Wednesday about disease distributions, and then continue that with today's presentation. So we were talking about the three main ways in which we describe the distributions of illness and injury in the population. One has to do with distribution in time, and we sort of talked about that. The second is distribution geographically. So this simply points out that rates of disease can vary geographically, perhaps due to differences in exposure to the causative agent or promoting factors, or perhaps the spatial clustering of individuals by disease susceptibility. But we have to be particularly alert to the possibility that rates differing geographically are artificially different, either because of better capturing of data in some areas than others, or perhaps differences in care-seeking and diagnostic procedures. So there can be a substantial amount of artifact introduced into those sorts of comparisons. So but here's an example of a disease and its distribution in the United States. This is Lyme disease. And here you can see the cases are pretty heavily distributed in the Northeast, in the upper Midwest, and then to a lesser extent in the western United States. And in fact, you could ask how much of this is due to better diagnosis and reporting, and how much of it is due to a real difference in the biology of the organism. And in fact, these distributions are well explained by the distribution of which spreads Lyme disease. So Lyme disease is caused by the bite of the Ixodes tick, and this very nicely matches the distribution of the Ixodes tick, but in fact with one key difference. So one might ask, why is there so much more Lyme disease in the Northeast than in California? Anybody know? Assuming that's a real difference, yes? So the western black fence post lizard or something like that, yes? It turns out that in the Northeast, these ticks, in addition to biting humans, primarily feed on deer and mice. But here in California, they also feed on a lizard, and there's something in the blood of the lizard that actually kills the Borrelia organism that causes Lyme disease and clears the infection from the tick. So ticks in the Northeast have about a 30% prevalence of infection with Borrelia, and ticks here in Tilden Park, it's about 1%. So there are biologically meaningful reasons why the incidence is quite different in these different regions, and these are true differences. And here you can just see for here in California that we do have Lyme disease right here in the Bay Area, and in fact in much of California where these ticks are found. So I'm going to skip over that. This would be another example of spatial distribution of an infectious disease. And here, these are broken out by in Milwaukee, where people get their water from. And here, the different rates, as portrayed by the different colors, are explained by the fact that these different areas get their water from different sources in the distribution system. And in this case, there was contamination of the water going to part of the city. And this was an outbreak of an infection called cryptosporidiosis, a parasitic cause of diarrhea that's commonly found in water. And here the geographic distribution is explained by the water distribution system rather than the distribution of ticks in the environment. Here you can get a sense of breast cancer. These are death rates rather than incidence rates, but as you know, breast cancer in women varies enormously by geography. So Marin County here in California has one of the highest rates of breast cancer in the United States. And you could ask the question, why is that? Is there something in the environment, in the water, in the air, that increases the risk of breast cancer, or does it have to do with the personal characteristics of women who live in Marin? And we think the primary reason rates are higher in Marin is because of those personal characteristics, but there are women who are concerned that there might be something in Marin County that increases their risk of breast cancer. Same thing is true for heart disease. Heart disease varies enormously by geography, so the rates of heart disease are much, much higher. You see here the red and orange colors in the southern United States, and much lower in other parts of the United States. So there are meaningful differences in virtually every disease by geography. And the contention is that we can learn something by studying those distributions. These are gonorrhea rates that also vary quite a bit geographically. So I'm just going to skip over all that, pretty much making the same case. Here are some data from Sri Lanka about the rates of malaria, and you won't be surprised to know that where you live in proximity to vector breeding sites determines your risk of getting malaria, because malaria is spread by mosquitoes which breed in water, and the closer you live to breeding sites, the more likely you are to get malaria. So there are lots of good reasons why geography would influence your risk of disease. Skip over that. Talked about that. And this would just be one more example. Some of you may be familiar with this cluster of childhood leukemia cases in, anybody here from Massachusetts? So how do you pronounce the name of that town? Woburn. Okay, so Woburn, Massachusetts, and this is a very, very famous episode of a cluster of leukemia cases. That is, here you can see the cases and their distribution, and here's an industrial complex, this particular story is told compellingly in both a book and a movie called A Civil Action. Anyone seen the movie? The book is much better than the movie. And this portrays this as pretty much an open and shut case of an industrial pollutant causing childhood leukemia. I can tell you it's not quite as clear-cut as that, and there are epidemiologists who think that that's not the case. But nevertheless, this book is really an interesting discussion of this entire episode. So if you're interested in environmental cancer, environmental exposures and cancer, this would be an excellent movie or book to take a look at. Okay, and then finally, in addition to time and space, we look at person characteristics because they're very important determinants. We've already beaten to death the topic of age, and age being a very important predictor of your risk of virtually every health outcome. But there are other factors, including gender and race, ethnicity, and occupation, socioeconomic status, nutritional status, etc. I'm going to skip over all the verbiage there. So if you're an infectious disease person, you know that pretty much the risk of every infectious disease varies by age. And for many infectious diseases, the highest rates are in very young children. Then they go down precipitously, so you folks are generally down here in the trough with the lowest rates of most infectious diseases. And then when you get to my age, your risk starts to go up. And this has a lot to do basically with your immunity. You'll see for many infectious diseases, infants in the first 6 months of life are generally have a lower rate of disease. Why is that? So there's a certain amount of transplacental transfer of antibodies, which are protective against many diseases. You are born with antibodies that you got from your mother. Those antibodies are catabolized, and over by about 6 to 9 months of age, they're pretty much gone. If you breastfeed, breastfeeding is a source of antibodies and other protective factors. But in addition, in the first few months of life, you aren't as exposed to the environment. Once you can start to crawl, you can sample your environment in ways that you can't when you are sort of confined to a chair or to a bed. So there are obviously also differences in exposure to infectious agents once your mobility increases, shall we say. Looking for the feral Cheerio on the floor and things of the like. So, but in general, age is a potent predictor of your risk of most infectious diseases. Here are data on traumatic brain injuries, hospitalizations for traumatic brain injuries, and here you can see very clear age patterns, so not so prominent for assault-related brain injury. Here you can see for falls, the highest risk of a brain injury from a fall is in the elderly, relating to a whole host of factors from dementia and frailty and osteoporosis and a host of other things. On the other hand, motor vehicle traffic-related brain injuries obviously occur in a different age group, going back to motorcycle helmets and a variety of other issues. So not too surprising that age is a powerful predictor of injuries. Here are injuries relating to household fires. Again, you can see that, in fact, the elderly are at greater risk of being injured in a fire, and again, presumably related to ability to exit from a burning building quickly, and things of the kind. So age is really important, and you guys are at the best age at the moment in terms of pretty much the risk of anything, but unfortunately, it's all downhill from here. Okay. Okay, so just to finish up, I'm going to skip over that. This is just to show you We were talking about obesity. This week's Lancet turns out to be devoted almost entirely to the worldwide pandemic of obesity. And so these are data that I just put in this morning. And here you can see from between 1974 and 2004, this is the prevalence of childhood overweight. You can see the U.S. is the world leader in childhood overweight, but all countries are seeing these substantial increases from less than a few percent in the U.S. now by 2006 up around 20%. And then this is adult obesity, prevalence of a BMI, a body mass index over 30 kilograms per meter squared. In Ethiopia, down around 1% or less. And in Tonga, 70% of the population is obese. So there are enormous geographic differences, but in general, worldwide, we are seeing these tremendous increases in overweight and obesity. Okay? Yes? So it wouldn't necessarily be a question of what my theory is. I would say in general the theories about why obesity is going up. So some people argue there's a genetic predisposition to obesity. That may or may not be the case. I have some colleagues who believe that infectious agents that are transmitted from person to person or in food might actually be associated with obesity, and there's some studies in mice suggesting that that might be true, but I think pretty much the leading theories have to do with increasing calories in and decreasing calories out in the form of exercise and activity. And in fact, there's even a huge difference in how many calories you burn standing as opposed to sitting. So the extent to which people spend all day sitting and not being active, taking in more and more calories, most people believe is the primary problem underlying obesity. There are alternative theories, but I think that's generally the one that's best accepted. Any other? Okay. So I want to then move on to today's topic, which is again fundamentally about distributions of disease in populations. I want to talk about two things. One is what factors affect that distribution, and take the disease of measles as an example. And then I want to spend a little time talking about very interesting studies that are called migrant studies, studies of what happens to your risk of disease when you move from one area that has a particular rate of a disease and live in an area that has a different rate of the disease. How does your risk vary or change when you move? Okay? But first, this question of measles, I want to share a few things with you. So this was a famous infectious disease person back in the 1940s, and here you can see his take on this. The simplest of all infectious diseases is measles. You can't be a whole lot more unambiguous about it than that. He considers this a very simple disease. And in fact, we've known a lot about this disease since the work of a famous Dane named Peter Panum, back in the 1840s, and he went to a place called the Faroe Islands, which were a Danish colony, if you will, in the North Sea, and studied an epidemic of measles. And you can imagine that in 1846, there wasn't a lot of laboratory support for studies of viral infections. Nobody knew what a virus was. But through careful epidemiologic study, Dr. Panum basically learned an extraordinary amount about this infectious disease of measles. He determined the incubation period was about 10 to 14 days. He determined that you are only infectious early in the illness and not later in the illness. He determined that measles produces lifelong immunity. Once you've had measles, you cannot get it again, despite, I'm sure, somebody here saying you know someone who had it twice. It basically doesn't happen. That it's not spread by inanimate objects in the environment. So what's that word? So what's a fomite? So are there any doctors or nurses in the room? So what's a fomite? So something like a toy or a ball or a payphone or a doorknob, any inanimate object where infectious agents can be placed on it and then be acquired from it. Every medical student learns to pronounce this fomites, but a few years ago a student in this class told me the word is in fact pronounced fomites, and I looked it up and she was correct. So for you doctors in the room, don't try saying that over at UCSF because they won't know what you're talking about, but that is in fact the correct pronunciation of this word. And that the other issue was that measles cases don't arise spontaneously. They basically always come from some other case. And at the time, people thought spontaneous generation was, in fact, a legitimate theory for this disease. So Panem really did pioneering work 170 years ago or so. And we've known all that for a long time. Here's Dr. Panem, a cheerful-looking fellow. Here are the Faroe Islands up here in the North Sea, very remote place. And if you go back and read some of his work, you can still go to the Faroe Islands. In fact, if you read some of his work, it was a pretty amazing place at the time. He talks about the diet. The main dish eaten was called rast, a half-spoiled meat or fish, which is basically hung up to dry. It's frequently half-rotten when it's eaten. It has an unpleasing, moldy appearance, frequently occupied by maggots. Sometimes cooked, but some people prefer it raw. Eating meat that's so badly putrefied, its stench nauseated me. So an interesting investigation to do. Here he talks about the fact that clothing was basically cleaned by dipping it in vats of urine, which they stored. They stored human urine in large vats for some reason, and they would use that to wash their clothes in order to get rid of the lice. So this was sort of an interesting, if you're interested in the early days of epidemiology, you can read the works of Peter Panem. Interesting guy. So in any event, what we know about this disease, measles, this is all basically correct information. The virus was first isolated in 1954. We've had a vaccine since 1963. There is only one strain of the measles virus. There basically are not multiple strains, so there's really only one measles virus. There are no natural non-human hosts or environmental sources. There's only a single route of transmission through the aerosol spread through coughing and sneezing. And basically 100% of non-immune individuals will get measles if they're exposed to the virus. So in a sense, this guy Maxey was right. This is a very simple disease, right? So given all this, you would expect the epidemiologic features of measles to be pretty consistent around the world, okay? And that's not the case. And so what I want to illustrate for you is, despite the fact that we have an infectious agent with these characteristics, the epidemiologic pattern of the illness depends enormously on social factors and on a variety of other factors. So let me just illustrate that. So that just says what I just said. Okay. So here, for example, this is the distribution of measles in Buffalo, New York in the 1960s, and in a place called Ungava Bay in 1949. So anybody know where Ungava Bay is? So Ungava Bay is in far northern Canada, a very, very isolated community, very similar to an island. Okay? So here you can see the age distribution of measles in Buffalo. Most of the cases occurring in children between 5 and 10 years of age. And here you can see in this year in Ungava Bay that basically cases occurring throughout the age range up until the age of 50. So how might you account for that very different age distribution? How could you explain this incredibly different distribution and who's affected by age?
Is that because in the isolated area no one had it and then it was distributed?
Exactly. So Ungava Bay is an isolated community, few people going in and out. When do you think the last measles case was before 1949? About 50 years ago. So about 50 years before this, there was measles there. Pretty much everyone developed measles and became immune. And then because it was an isolated community with few people going in and out, measles wasn't reintroduced until 50 years later, when everybody born since the last epidemic was fully susceptible, right? Meaning that pretty much everybody under the age of 50 got measles, and nobody over the age of 50 got measles, right? Whereas in Buffalo, what's happening with measles? Basically, it's a large enough population that measles virus is circulating all of the time. It never disappears, right? And so you get exposed to it primarily in rich countries at this time when you leave the house and go to school, right? And that is why you get this age distribution. But by the time you're 10 or 15 years of age, everyone has had measles. So there are no measles cases in anyone over the age of around 15 or 20. Okay, and here you can see this was basically an epidemic with no cases for basically the 50 years before that, as opposed to these cycles of measles with every other year having more cases and every other year having fewer cases because of the number of susceptibles in the population. Okay, so just a very simple example of this profound difference. And in fact, the things that influence the descriptive epidemiologic features of measles include the size of the population. If it is a small population, the virus will die out and won't be sustained. If it's a large population, like in London or New York, you will have constant circulation of the virus. The degree of isolation of the population, family size, child spacing, and crowding. Why do they matter for a disease like measles? Why would child spacing, what does child spacing mean? The number of years between births in a family. So my older brother was 3 years older than I am. My younger brother is 20 years younger than I am. That's what we mean by child spacing. Okay, so why would child spacing influence the descriptive epidemiology of measles? So it basically changes the age at which you are most likely to come in contact with the virus. In terms of older siblings coming into the house and introducing the virus, it changes the age at which you come in contact with the virus. Okay? Patterns of social interactions in the community, as I'll show you, and nutritional status is an incredibly important factor, at least in the case fatality. So in fact, many of you know there's currently a famine going on where? In Somalia. And in that setting, measles is virtually always a death sentence in any young child. When you are severely malnourished, if you get measles, you almost always die. And so nutritional status is a potent predictor, at least of your outcome once you get measles. The presence of HIV in the community also changes your likelihood of getting very sick or dying if you get measles. And of course, now that we have a vaccine, vaccination coverage clearly influences distribution of the illness. So this just shows you, for example, the peak age of incidence for measles in poor countries in the old days compared to rich countries pre-vaccination and post-introduction of vaccination. And what you see is that in poor countries, the peak age of getting measles is pretty much in the first 2 years of life. So not in the first 6 months of life when you have maternal antibodies, but once those antibodies wear off, you basically will get measles before the age of 2. Okay? As opposed to in rich countries, where in general, the peak age before vaccine was introduced was about school age, when you went off to school, and post-vaccination, why does vaccination change the peak age of getting measles? Why does vaccinating a substantial part of the population change that? Exactly. You, on average, are going to come in contact with the virus at an older age if there are fewer cases circulating in the community, right? So these are very well described patterns, present for many, many years. But here are the data from West and Central Africa. The peak age, the median age of getting measles in Africa, depending on whether you live in a dense urban environment, a dense rural environment, a rural environment, or an isolated rural environment. Why? Again, basically because of your likelihood of coming in contact with the virus at an earlier age is much greater in a densely populated community than in a sparsely populated community, right? I mean, it just sort of makes sense, but in fact it is a potent predictor. Here's the effect of family size on when you get measles. So if you grow up in a family with 3 or more children in it, you tend to get measles at a younger age. If you grow up in a family with fewer children, you tend to get measles at a later age. Okay? The exact same phenomenon. So family size matters. This has to do with the dispersion of the population and how long epidemics last. So all of these, despite it being a single virus, despite the fact that everyone is basically born and will be susceptible within 6 months, the patterns vary enormously depending on population and social factors and interactions for very, very good reasons. Okay, so we'll skip over this. Factors influence the age of acquisition or the duration of maternally derived protection, mother's antibody levels, efficiency of antibody transfer across the placenta, the rate of basically destruction of the antibodies in the infant, breastfeeding, and of course, whether the mother got her antibodies from vaccine or from getting measles. If the mother gets her antibodies from measles, she on average has a higher level of antibodies than a woman who got her antibodies from vaccine. Okay? Exposure to other people, et cetera. So all of this makes sense. It just illustrates this point. What influences your risk of dying if you get measles? Again, age at onset is critical. The younger you are when you get measles, the more likely you are to die. Whether you're a primary or secondary case in the household, this is really interesting. If you are the first case in a household, you are less likely to die than if you're a second case in a household. How could that be? And this takes into account age. So it isn't just that they are younger kids. This takes into account age. How could the second child in a household be more likely to die than the first child who gets it in a household? Yeah. Pardon?
I'd like to guess. Maybe because the second child is exposed to strain that's stronger?
Exposed to a strain is stronger. There's only one strain of measles virus. So that can't be the case. It's the same virus. Nope, yeah. Complacency. I don't think so. In fact, nobody really understands this phenomenon, but the best guess is you get a higher dose of measles virus if you're exposed in your household than if you're exposed in the community. So you start out with a higher dose of the virus. Now, there's no proof of this. I think it's the most plausible explanation, but nobody actually has a good explanation for this. But it's been a well-observed phenomenon in studies of measles, particularly in poor countries. Vitamin A deficiency is a very, very important predictor of your risk of dying to measles. Vitamin A deficient children are much more likely to die of measles if they get it. Your weight for age, in other words, your level of nutritional status, your HIV status. So measles in a rich country like the United States, where people are well-nourished and get it at an older age, is generally a self-limited illness from which people recover. Measles in the setting of a famine in Somalia, where children are younger and are malnourished, as I've said, most of those children, if they get measles, will die. Okay? So it's a very different disease in that setting than it is here. But when we had a large measles epidemic in California in the 1990s with over 10,000 cases, we had almost 100 deaths from measles in California. So measles can kill children in rich countries as well as in poor countries. Okay, so I now just want to illustrate this concept of migrant studies. So these are really elegant, interesting studies that you should be familiar with. These are studies that take advantage of the migration of large numbers of persons from one area to another, and then comparing the morbidity or mortality experience of those who migrate to those who remain behind or to those who already live in the area. Okay? That's fundamentally what's going on. And what they're intended to do is try and elucidate the relative importance of genetically determined host factors from endogenous environmental factors in disease causation. We're going to talk in a few weeks about ecologic studies. Migrant studies are a form of ecologic study, okay, in which we are studying groups, collecting data on groups of people rather than on individuals, or analyzing the data on groups. So just some examples of how people have done this. One is cardiovascular disease in cancer in Asians who move to the United States compared to Asians who stay in Asia. Okay? Or multiple sclerosis in those who move to Hawaii from the U.S. mainland, or in Europeans and others moving to South Africa or Israel. Or malignant melanoma in Europeans and others moving to Australia or New Zealand, or cardiovascular disease in African Americans who move from one part of the United States to a different part of the United States. So what you basically have is people moving from an area where the rate of disease is high or low to an area where the rate is different. And what happens to their rate? Is it the same as the area they left, or does it become that of the area to which they move? And does it matter at what age they move? Okay, those are sort of the fundamental questions here. So the impetus for doing these studies is that you have descriptive epidemiologic studies showing differences in rates geographically. Okay? So here are data, for example, on cancer of the stomach. These are old data from 50, 60 years ago. Cancer of the stomach in men and in women. And here you can see Japan at the top, and you can see U.S. whites at the bottom. So very, very large differences in the rate of stomach cancer. And so you might ask the question, what happens when Japanese move from Japan to the United States? Do they still have a high rate of stomach cancer? Or does it go to the rate of U.S. whites? What do you think? That's what a migrant study is intended to ask. You can obviously only do it when you have large numbers of people moving, right? So what do you think? Any guesses? We have any Japanese Americans in the room? Gradually goes towards that of the population in the area to which people are moving. Okay. So just to point out that in order to do these studies, you need migration of large numbers of people. You need to be able to ascertain the migration status of the individuals, and you need to be able to ascertain the outcome status. Okay, so who's a migrant, who isn't, who gets, in this case, stomach cancer, and who doesn't, right? This will be, so here you can see rates of gastric cancer. These are for Chinese and for Japanese in different parts of China. Hawaii and Los Angeles, and again for Chinese, you can see this fourfold difference among men, about a threefold difference, 2.5-fold difference among women in the rates of stomach cancer. For Japanese, again, you can see about a fourfold difference, right? Oops. So here are these very, very old data. These are men, these are women. So these are U.S. whites, and these are the rates of stomach cancer by age, and this is on a semi-log scale. Okay, so you can see, as we'll talk about for all cancers, for most cancers at least, your risk of cancer goes up with increasing age. And here you can see U.S. whites. Here you can see Nisei and Issei, and here you can see Japan. So anyone know what Nisei and Issei are? We really need a Japanese American here. Pardon? So which one is the group who actually were born in Japan and moved to the United States? Those are this group here. And these are the first generation born in the United States. Okay? And in fact, you can see these much higher rates in Japanese who were people who were born in Japan and moved to the United States. Pretty much indistinguishable from just a little bit lower than people born in Japan. Their offspring, the first generation in the U.S., have lower rates, but still higher than those born than U.S. whites. Okay, and by the second, third, fourth generation, in fact, these differences pretty much disappear. Okay, so what does that tell you about stomach cancer? So based on diet, so any other formulations? Pardon? Regionally related, what does that mean? So there's some difference, but you're not sure it's diet, right? And I think that's probably a better formulation. I'm not sure we know it's diet. Diet is absolutely one of the factors people think might be really important. But what you'd really, I think, in honesty say is something is different in Japan than in the United States. This is not a change in the genetics of people in one generation, right? So there might be a genetic component to stomach cancer. I don't know. Maybe Michaela will tell us. Yeah. Right. So it used to be that people thought that, and it probably may still be the case, that stomach cancer was primarily related to diet, and it had to do, for example, with consumption of foods that were preserved with materials containing nitrates and other substances that might be carcinogenic. Okay? And that, for example, why did stomach cancer rates plummet in the United States over the last 100 years? Anybody know? Ascorbic acid? I never heard that. Neutralizes nitrates. So with the bacon, you have a glass of orange juice, and that neutralizes the nitrates in the bacon. I have no idea if that's true. It's an interesting theory. Some people think it has to do with the introduction of refrigeration and the fact that we don't need the same preservatives, and that therefore, because we can keep food fresh in refrigerators. I have no idea if that's true. But in the meantime, people have actually learned, and a Nobel Prize was given for the discovery that, in fact, stomach cancer is one of the 3 most important cancers in the world caused by an infectious agent. And in this case, it's Helicobacter pylori, a bacterium, which is the cause of stomach cancer. So that is absolutely the case. And so then the question becomes, does this all have to do with differences in the prevalence of infection with Helicobacter pylori in the stomach? And the answer is it almost certainly does. Okay, there are enormous differences in the prevalence of infection with Helicobacter pylori, and they're much, much higher in Japan. And this, by the way, is just to show you that not all Japanese have the same rates of stomach cancer. Within Japan, there are enormous regional differences in the rate of stomach cancer. And I believe these also correlate with the prevalence of Helicobacter pylori infection. Now, that doesn't mean that nitrates might not be important or that other components in food might not be important. It's absolutely possible. And there's no question that when people migrate, their diets tend to change. And even if their diets don't change, their children's diets change and their grandchildren's diets change to become more and more like the diets of the population in which they're living. So maybe diet has something to do with it as well, but Helicobacter pylori almost certainly is a critical factor. Okay? But just an example of a migrant study. I'll skip that. Here you can see Warren Winkelstein is our former dean, former chair of our department. Here you can see his article on the subject of stomach cancer in Japanese moving to Hawaii and California, but I personally can't read this, so I don't think he actually wrote it either, but nevertheless probably translated. So another example has to do with multiple sclerosis. What's the cause of multiple sclerosis? Well, nobody else knows either, so don't feel bad. It's a completely unknown etiology. It has an autoimmune component. It probably has a genetic component, but nobody knows what triggers multiple sclerosis. It's a disease, a terrible disease of unknown etiology. And when people have done descriptive studies, they've noticed that in the United States, the incidence and, in this case, the prevalence of multiple sclerosis varies by geography. Okay? So the highest prevalences and incidences of MS are in the more northern parts of the United States, and there are lower prevalences in the more southern parts. And this has been shown pretty much all around the world. The closer you are to the equator, the lower your risk and the lower your prevalence of this disease. And the farther north or south from the equator, the greater your risk of multiple sclerosis. So how could that be? Why is that? Nobody knows. But here people are asking the question, well, what happens if you move from an area where MS is common or uncommon to a place that has the opposite? Okay? And in this case, it was the U.S. military asking the question among soldiers who move to Hawaii from the mainland of the United States. Okay? And so here what you can see, and this has been replicated in many studies, is it depends on how old you are when you move. Okay? And if you move before the age of 15, okay, if you move when you are very young, you acquire the risk of multiple sclerosis in the area to which you move. If you move after the age of 15, you pretty much have the risk of multiple sclerosis of the area you came from, suggesting that whatever it is that causes it is probably acquired relatively in the first 15 years of life. Now, is it an infectious agent? Nobody knows. So does it answer the question of what causes multiple sclerosis? No. Just like those cancer studies, gastric cancer studies don't say whether it's diet or something else, but they sort of can potentially help you focus in on some of the environmental hypotheses that might explain this. Okay? Yeah, sorry. Zero. Okay. So here you can see prevalence of multiple sclerosis per 100,000 population among immigrants to Hawaii. And here you can see that, again, basically, if you move to Hawaii, which has a low rate of multiple sclerosis, under the age of 15, sorry, that doesn't seem to be working very well, you basically have a low rate. If you move at an older age, you have the higher rate that's present in the 48 states of the continental United States. Okay? So it depends on the age at which you move. And this has been replicated again. You probably know that large numbers of people over the years have moved to the country of Israel back in the 1940s and 1950s. People moved to South Africa, and people have done similar migrant studies of people moving from Europe or from various places to these countries to try and elucidate some of the causes. So here are studies of multiple sclerosis in white South Africans, South African English, and immigrants. And basically, let's see, who's in which group here? So these are the immigrants here. These are South Africans down here. And you can see that basically people moving to South Africa, which has, again, a low incidence, a low prevalence of multiple sclerosis, moving from countries with a high incidence or prevalence, have the incidence or prevalence of the countries they came from. Okay, because these are mostly adults who are moving there. These are not young children. Okay, so does that help us figure out what causes MS? I don't know, but they're sort of interesting studies. Same thing in Israel, migrants to Israel. I won't sort of go over that. Now here, this is what we'll end with. This has to do with cardiovascular disease in non-Hispanic blacks and whites in New York City in the late 1980s. So here you can see these are death rates. This is cardiovascular disease. This is coronary heart disease, and this is stroke. So all of the black bars here are whites for comparison. Okay. But these first set of boxes are blacks born in the South who moved to New York. The second columns are blacks born in the Northeast. And this third column are blacks born in the Caribbean. So these are all African Americans living in New York, but their rate of cardiovascular disease is different depending on where they came from, whether they were born in the Northeast, migrated from the Caribbean, or migrated from the southern United States. So what are possible explanations for that? They in general, you can see in general with no, I'll take that back. For cardiovascular disease, you can see that blacks born in the South have much higher rates than whites or these other groups, but there's this clear gradient depending on where people were born. They're all black, and they're all living in New York City. Any explanations? Yeah?
Probably multiple, but there's some dietary things.
So maybe they have different diets depending on where they were born.
And probably an effect of social status in the South affects them before they move. And they just
So maybe this is all due to differences in socioeconomic status, and we're going to come back to that. That's what we'll call confounding. So it's not really due to where they came from or where they were born. It's more to do with their socioeconomic status. So has that been adjusted for here? Okay. So again, these studies don't answer the question of what factor is responsible for these differences. They're thought to be helpful in potentially targeting then the studies, the follow-up studies that you might then use to look at that. But there are these interesting studies that look at people when they move, what happens to their risk of disease. So you should be at least familiar with these. Again, they're a form of ecologic study. Okay? And we'll come back to ecologic studies later in the semester. So basically, these migrant studies show that migration for many diseases does have an important, may or may not have an important influence on the risk of disease. They tell us that to the extent that your risk does change, that it's not so much genetic and it must be environmental factors, but it doesn't tell you what environmental factors they are. Are they diet? Are they air pollution? Are they a host of other things? And how much of this might be due to confounding by various other things. Okay, so you should just be familiar with these migrant studies. Okay, any questions about any of that? Yeah?
On that
Of whites born where? So it's a good question in terms of whites born in the Caribbean moving to the United States. I don't think there are very large numbers of them. And so if you don't have enough people in a group to study, you really can't do these kinds of studies. There are fairly substantial numbers of blacks who've moved to the United States from the Caribbean. I'm not sure how large the white populations in various Caribbean countries are in the first place, but probably not large numbers of migrants. Okay, yeah. What amount is significant? So you'd say, well, should we put error bars or 95% confidence intervals around these to see whether these are significant differences? And that's a fair question, and obviously this graph doesn't do that. You know, I don't think you'd want to say anything that these are different in any way, but I would guess that that is significantly different from those. If I had to guess, my eyeball calculator would tell me that that's a statistically significant difference. But it's a fair point. Okay. Any other questions? Okay, so on Monday and Wednesday of next week, Mahasan will be here talking, giving you a brief introduction to the history of epidemiology, to some of the key ethical challenges we face when we study humans as epidemiologists. And so those are important sort of backgrounds, if you will, to epidemiology. Okay?